What is glioblastoma multiforme, or GBM? Glioblastoma multiforme, or GBM, is the most aggressive type of astrocytoma. The cerebral hemispheres are the most common locations affected, particularly the frontal lobes as well as the temporal and parietal lobes. Glioblastoma multiforme grows fairly rapidly and spreads deeply into the surrounding brain tissue and often even to the other side of the brain. In some cases, GBM can form from a more low-grade astrocytoma or an oligodendroglioma. GBM is very difficult to treat effectively due to a number of factors, including its tendency to spread quickly and deeply into the surrounding brain, as well as its resistance to other types of treatment, or relative resistance to treatments such as radiotherapy and chemotherapy. In adults, GBM occurs most commonly in men and tends to occur most commonly between the ages of 50 and 70.
The idea is that we not only look at the impact on survival, but we also look at patient-reported outcomes, also called PROs, and those include quality of life as well as symptom burden. And Dr. Wafel leads the effort looking at neurocognitive impact of the therapy. And we really think looking at all of those outcomes together will give us a better picture on the impact of the therapy on the patient. We looked at the study, RTOG 0825, is really comparing the addition of bevacizumab versus placebo to temozolomide in patients with newly diagnosed glioblastoma. So our hope was that the addition would not only improve survival but improve patient function. Unfortunately, what we found was that patients had more symptom burden on this study. So patients had more fatigue, they had more treatment-associated symptoms, but they also had more symptoms that we think are related to the tumor, so self-reported cognitive symptoms as well as neurologic symptoms. So we were surprised by that. We were hopeful that as the treatment would control the tumor, hopefully it would make people feel better.
So we undertook this study, again, looking at survival outcomes, but while most studies in the past have used just traditional endpoints like overall survival or radiographic progression-free survival outcomes, this study also wanted to characterize at a more fine-grained patient level the experience that the patient was having when receiving these treatments. So we incorporated measures of neuropsychological function or cognitive tests, as well as self-report questionnaires that the patients completed looking at their symptoms and quality of life. Together, then, what we were able to do is to really characterize any differences between arms in survival times in terms of how that impacted the patient. So was it of clinical benefit or not to the patient? Unfortunately, what we detected is over time, in patients that were progression-free, there was a greater chance to have deterioration. There was greater deterioration in the Avastin arm than in the placebo arm. And this was true in global cognitive function and aspects of processing speed and executive function as well.
Was that surprising to you?
It was disappointing, certainly very disappointing. You'd love to see these agents that are able to make improvements in the scan also result in improvements to the patient, and that just didn't appear to be the case.
The expectation was that regardless of the outcome of the trial, that there may be a subset of patients which actually respond much better than even the overall group would indicate. So the idea was to look for molecular factors that could identify those patients and could eventually be used to select patients for this treatment. The molecular tool that we've identified looks at a set of genes, 10 genes in fact, that appear to reflect an enrichment for genes that are involved in what are called mesenchymal cells, cells that are highly invasive and show a lot of blood vessel formation, so-called angiogenesis. And so this test in and of itself doesn't determine if a tumor is mesenchymal or not. It's specific at looking at response to bevacizumab. However, it does appear to correlate tightly with the degree of mesenchymalness of the individual's tumor. Any study like this, any biomarker like this that's been developed clearly requires a lot of validation before it enters clinical use. One of the key things we've done, though, in developing this is designed it to work on the kind of tumor material that's most readily obtained, the so-called formalin-fixed paraffin-embedded tissue, the archival tissue, that any hospital obtains for any patient with this brain tumor. So should it be validated, it would be very easy to turn this into a diagnostic that could be used to select patients in a rapid process and allow them to get the optimal treatment.